So I'm pleased to be joined now by Dr. Pat McCarthy. Pat's known to many of you in Northwestern Chicago. Thank you for joining me.
Thanks, Randy. Thanks for asking me.
So Pat, let me ask you, we're going to talk about tricuspid valve repair surgery. What's the current state of art in tricuspid valve surgery?
Well, it's much more aggressive than it was, say, 10 years ago.
Right.
And if you actually look across the U.S. in the STS database, the number of tricuspid operations has gone up 5 times.
Okay.
So what's happened is that people are actually realizing if you do a mitral operation and you don't treat that tricuspid, it has bad outcomes for the patients. Not only does the TR persist or get worse over time, but the patients feel worse. Heart class, New York heart class is worse, and so we're much more aggressive about it.
Yeah, I mean, I've got many patients I've got a series of patients who were repaired 10, 12 years ago, great mitral repair, but the tricuspid was not addressed, and it's problematic. Do you think that that we're appropriately addressing this more? In other words, how do we get the message out, and when do we intervene on the tricuspid valve?
Well, I think if you look at, say, the European guidelines, they came out after the U.S. guidelines, and they're even more aggressive about it. And so I think that they've always, because of more rheumatic disease, been more in touch with it over there, and so they've paid more attention to it. So I'm hoping that the new guidelines are going to reflect that. And so certainly patients that are 3 or 4 plus TR, if you're there for surgery, it's the standard of care, everyone treats it. But 2+ in many of these patients always should be treated as well. And the exceptions would be, say, a 88-year-old patient with multiple other comorbidities where you just don't want to be on pump that long. But the vast majority of patients were much more aggressive.
What about the tricuspid annulus size? I mean, is there a size? And I know the European guidelines, and should we adjust it for body surface area and things like that?
So the European guidelines used to say 45 millimeters or greater than that, you should treat it. They've actually come down to 4.0 centimeters now, so 40 millimeters. And so many of us use that as a guideline, and again, putting it in the clinical perspective. But even patients that have no TR, if they have a dilated annulus, if you don't treat it, if you follow them after their mitral surgery, many of them develop TR, and then also that group of patients may not do as well.
What about patients who have atrial fibrillation? Obviously, it's because that can change the whole schema of the tricuspid annulus. Yeah. You doing those patients too?
So in that group of patients in particular, we're also very aggressive about treating the atrial fib. So the Heart Rhythm Society guidelines, along with the Society of Thoracic Surgeons, recommends that if you're there to do a heart operation, that you should treat the atrial fib in that group of patients, again, because of the outcomes with AFib ablation. But in this group of patients, again, if you leave the tricuspid regurg and if the patient is in atrial fib, it's going to progress. So it becomes even more aggressive in that group. So we, for instance, would do both.
Right, and I know that's why I asked, and I think it's the right thing to do. What, Pat, the guidelines, you said you hope that the new American guidelines are, mirror or mimic or do like the Europeans did. Have we had tremendous advances in tricuspid valve surgery?
I think we've gotten a lot smarter about it. I think just as we learned about ischemic mitral regurgitation, what are the risk factors for failure, we've learned a lot about tricuspid regurgitation now. Suture annuloplasty isn't as durable, and so some type of ring repair is actually a better long-term result for that group of patients. And what we really learned is the amount of tethering. And so if the tricuspid looks like this and you put a ring around it, it should be fine. Right. But if the tricuspid looks like this and you put a ring around it, if there's that much tethering, you may not get a good result. So that may be a patient to do cord-sparing replacement, or we're looking at using a patch to extend the anterior leaflet. So there are new sort of surgical tricks to treat the really severe patients.
That's interesting. Final question is, in our lifetime, are we going to have a percutaneous treatment for the tricuspid?
Oh, sure. Yeah, there's no question about it. I mean, just like we're working on percutaneous mitral replacement, and we've already done valve-in-valve for patients with a failed tricuspid prosthesis, which is not common.
Interesting. Well, I mean, I think, through your leadership, and certainly I think being more aggressive in the appropriate patients with primary repair of the tricuspid is very important when you're doing mitral surgery, isn't it?
Agreed, yeah. You know, an interesting area too, Randy, that I also hope that the guidelines reflect is a patient with just isolated tricuspid regurg. If you look at the guidelines, it's interesting. They have statements in there saying that patients with TR have a poor prognosis, but then it's a class 3 indication to operate on a patient with isolated TR without much in the way of symptoms. But at the same time, the guidelines say currently that that group of patients are at risk for adverse events. And what happens is we wait too long and the patients get a blown right ventricle is dilated, finally develop symptoms and a bad liver, and finally get referred for surgery. And so again, the European guidelines have moved that up to a 2B. And if you start to look at what we do with asymptomatic mitral disease, where it's a 2A, for patients that really have severe TR, we ought to be looking at how the ventricle responds and not looking at the symptoms alone.
Absolutely, and you know, the other key thing is really to educate your cardiologist, because
I'm working at it all the time.
They're a hard group to educate.
They are.
I mean, especially about the tricuspid valve, because they don't often think about it.
It's true.
So anyhow, but Pat, I appreciate all you've done. And your thoughts on this meeting? It's
an outstanding meeting. I've actually, this is one of the few meetings where I actually go and listen to all of the sessions because there's so many of my peers that have great ideas, and I learn a lot of tricks.
That's great. Well, listen, thanks so much for visiting with us. Thanks for all you do. Thank you very much.